Okay, so I'm Richard Oehler, and today we're going to talk about Nocardia, a heartless disease, just by name, not by manifestations. Um, so the reason why I wanted to talk about Nocardia today, it's a very important disease in a certain patient demographic. It's also one that perhaps we don't get as much understanding about because we don't see a lot of these patients. When I think about the cases of cutaneous nocardia that I've seen, it's certainly within a handful. Now, occasionally we do see it more in pulmonary disease and disseminated disease, but it's something we don't see a lot of. How many of you have seen a case of nocardia in the last year? Raise your hands. I'm talking to the audience here, and several people have, so it's fairly common in our immunocompromised population. How about a case of a cutaneous nocardia? And then the hands don't go up in the audience. So, all right. So these are our talk objectives today. We're going to talk about microbiology of nocardia, epidemiology, risk factors, clinical manifestations, treatment, and other considerations. And my thanks to the fine infectious disease site Up to Date for their assistance in producing this presentation. So as we said before, nocardia is an uncommon pathogen. We don't see it a lot in immunocompetent individuals. But where it's important is it has the potential for local or systemic suppurative disease in humans and animals. And although it's typically associated with the immunocompromised, about 2/3 of the cases, in about 1/3 of the cases, it's an immunocompetent patient. So think about this as the law of thirds. 2/3 of cases in the immunocompromised, 1/3 in immunocompetent patients. And this is Nocardia asteroides on a culture plate. What's more, Nocardia is, I think, atypical in that it has the ability to disseminate widely to almost any organ. Perhaps the lung is the most likely to be involved, but it can also, of course, as we know, spread to the CNS. It can also involve the liver and also other organs as well. If you look at case reports, there are odd cases of nocardia dissemination to other organs. And it can relapse or progress despite appropriate therapy. You can have a patient you think is on appropriate therapy, you're treating them aggressively, and yet the disease either continues to progress or they experience a relapse. Now, nocardia used to be considered a fungus because it has this hyphae-like appearance. You can see it here on the left. But when there was an investigation of its cell wall structure, it actually was more consistent with a bacteria. So nocardia is actually a bacterial organism. And it's caused by aerobic actinomycetes in the genus Nocardia. Now, what are some other aerobic actinomycetes? These include Succinct, Rhodococcus, and Rhodococcus has a similar presentation in the lung, for example. The streptomycetes, but also Mycobacteria and Corynebacteria. So think of all of these as being morphologically similar. Perhaps that explains why they can be in the differential. And we know the morphology of nocardia as being these very delicate filamentous gram-positive branching rods. We see an example of that on the left here, on gram stain, of course. And we also know that nocardia is acid-fast stain positive, and specifically modified acid-fast stain is used for the diagnosis of nocardia. Please note that a way to differentiate these actinomyces stain acid-fast negative and are anaerobic. So think about the differences between actinomyces and nocardia, that they're very similar in morphology, but they have those differences. So here's a gram stain on the left and a modified acid-fast stain on the right. So just for board purposes, you know what these look like on stains. And obviously, the modified acid-fast stain on the right here, you can see the branching filamentous organism sticking out very much of a contrast in the blue background. The distinguishing characteristic with the modified acid-fast stain, if I remember correctly, is because the nocardia have these very long cell wall lipids, and because of that they resist decolorization with the carbol-fuchsin stain, if I have that correct. So Nocardia species, there are many of them. There's about 80 species, and out of those 80, about 33 can cause disease in humans. And when I learned about Nocardia in my fellowship, I learned about Nocardia asteroides and Nocardia brasiliensis, right? Those are the two differentiating most significant species in humans. But Nocardia asteroides is actually now reclassified into several different subspecies. There's Nocardia asteroides sensu strictu, the specific strain, but then there's all these other substrains which are actually the pathogens that cause disease in humans. Nocardia farcinica is the most resistant and it's the most likely to disseminate, and Nocardia nova is the most commonly isolated in humans. So think about farcinica and nova as being in the asteroides complex and being the most clinically significant strains among the asteroides complex of organisms. And then we remember that Nocardia brasiliensis is also a significant species outside of the asteroides complex, and my understanding is that it will soon also be further classified. So we may see other strains being relevant, but think about farcinica and nova, and farcinica being the most severe and the most fearsome of all the asteroides complex. Now, Nocardia species are not they're not commensals. They're not part of the normal flora. So think about any Nocardia isolation from any clinical specimen as being significant. It's not normal to have Nocardia in your clinical specimens. And it's an environmental contaminant, so it's found in the soil, decaying vegetable matter, aquatic environments, anything you would see in a hike in the in the woods. Is associated with Nocardia. And because its characteristic is it can become airborne, particularly in dust particles, it's easy to understand why the pulmonary tissue is most likely to be affected. So it's easily inhaled, and that can lead to lung disease, particularly in the immunocompromised. Now, what are some other modes of entry? You can ingest it via contaminated food, such as in this foodstuff, and because of the potential for legal implications, I have blacked out the name, but an example is listed there. You can get it traumatically inoculated. The case that I remember and that we wrote up at Moffitt a few years ago is a gentleman who was cleaning out his gutter, and he scraped his arm. He was an immunocompromised Moffitt patient. He scraped his arm on a gutter, sustained a cut or abrasion, and then developed a cutaneous nocardiosis. You can also get nocardia from medical devices like catheters, for example, or during surgery. So it's a nosocomial complication. And because it's an environmental pathogen, you can even get it from animal scratches or bites. So think about it in someone who has a bite infection from a domestic animal or another animal, and then experiences a chronic cutaneous syndrome. What's that? That was a cat. The one on the top or the middle? It's a man being consumed by a potted meat. I can't mention the name for legal reasons. So maybe you're not familiar with. If this were Hawaii, we would all love this particular product. But okay, so what are the frequency of species identified in the U.S.? There's an article in CID last year that identified the most common, again, is Nocardia nova, and I think I talked about that. The Nocardia nova is the most frequent pathogen, not the most fearsome. That's Farcinica. Think about fearsome and Farcinica. Brasiliensis follows. Farcinica is third, and then you see the others listed there. So Nocardia nova is the most common species in the U.S. that's identified most frequently in specimens. So again, think about this as a disease of thirds. Immunocompromised patients are 2/3 of cases. And so this is a gentleman who's maybe getting his chemotherapy or who's had a stem cell transplant, for example. And you want to consider nocardia again being associated with glucocorticoid therapy. So think about patients on prolonged steroids being susceptible to nocardia. But also think about both the solid and stem cell transplant patients, those who have both liquid and solid tumors, and in some cases HIV infection as well. There's an increased risk from glucocorticoid therapy, and among the patients who get it who are associated with malignancy, there's an exceptional association with patients who receive calcineurin inhibitors, like tacrolimus, for example. So patients on tacrolimus, think about association with Nocardia. Among the organ transplant patients, the highest association is in the first year, and those patients who are not on steroids have a lower risk. So if you're steroid sparing, your risk of Nocardia is less. The highest risk among organ transplant patients are in the lungs and hearts. The lowest risk is in liver and kidney. And there's also an association with CMV disease in the preceding 6 months. So if you see a patient with CMV disease in the previous 6 months who is both a solid or stem cell transplant patient, there's an independent risk factor for also having Nocardia. Now, believe it or not, association with Nocardia and HIV is somewhat less. There is an association, but not as much. Where you tend to see it is in the most severely immunocompromised patients, the patients with advanced HIV disease, very low CD4 counts. But as it turns out, septra prophylaxis in HIV, of course, is protective against Nocardia, so that may be one of the reasons why there's less of an association with HIV and Nocardia. These are some other conditions that can also be associated with nocardiosis. Note diabetes, patients with ETOH abuse. There's also an association with chronic granulomatous disease. The TNF-alpha inhibitors, of course, like infliximab, COPD, and also occasionally we see concomitant mycobacterial disease with Nocardia. And I'm thinking of a patient that we may have seen in the last couple years who had a history of mycobacterial disease and who then went on to develop nocardiosis. So what are the commonest sites of involvement for Nocardia? The most common site is the lung. That's 39% of cases in this review in Clinical Micro. But once you get beyond pulmonary disease, multi-organ involvement is the second most common clinical manifestation. So you may see someone with pulmonary disease and visceral organ disease, or maybe pulmonary disease and CNS disease, which of course is very common in patients who have pulmonary involvement. And then beyond that, you have CNS disease proper, and typically this is a syndrome of dissemination, but you can also have primary CNS disease. Cutaneous or lymphocutaneous disease follows, and then there's a host of other syndromes that fall after that. So remember, this is a disease of thirds. So pulmonary disease is about 2/3 of cases. So think about 2/3 immunocompromised, but 2/3 of the clinical manifestations are pulmonary. Remember, any culture of Nocardia in the lungs is significant. This is not a commensal organism. Patients can present both acutely with acute pneumonia, but they may present with a more subacute or chronic syndrome occurring over weeks to months. And the typical presenting symptoms of pulmonary involvement: fever, night sweats, fatigue, again, remember, very similar to mycobacterial disease or rhodococcus. Weight loss, they may have dyspnea, they may present with hemoptysis, they may have pleuritic chest pain. Now, here's an important fact to remember about pulmonary Nocardia. 50% of pulmonary cases disseminate, most typically to the brain, but it may be other organs as well. And common complications that you may see with pulmonary involvement of Nocardia include empyema. You may get mediastinitis. Pericarditis is a important clinical syndrome that requires surgical involvement, and SVC syndrome has also been described among others. And this is a patient who presents on X-ray with pulmonary nocardiosis. You see a very impressive right-sided pulmonary infiltrate associated with some perihilar thickening and perihilar process, may present again with an associated mediastinitis. This is a 26-year-old male allogeneic stem cell transplant patient with graft versus host disease who presents with pulmonary nocardiosis. There was a review of CT findings in Nocardia, and the conclusion was that pulmonary nocardiosis can present with either consolidation, both cavitary and non-cavitary, either as a single focus. You can also have multinodular disease, and you can also have involvement more in the periphery of the lung that extends to the pleural space. As a matter of fact, this is a relatively uncommonly described syndrome, but this is a patient who presented with chronic granulomatous nocardiosis due to Nocardia asiatica. So again, this is not commonly seen, but occasionally you can have chronic granulomatous nocardiosis, presentation of a chronic process, in this case presenting with a loculated effusion. Now, how about CNS involvement? Again, typically this is a complication of pulmonary disease. About 44% of disseminated cases, 44% I should say, occur as a result of dissemination. About 20% of the time it's a primary CNS involvement. It usually presents as a parenchymal abscess, but it can present in any brain region, so you don't have to have it typically in the temporal lobes or the frontal lobes. It can really be anywhere. Patients may present with fever, headache, meningismus. They may present with a seizure. They may have focal deficits. You know, what's happening with this person? They don't seem to be the same person, or they have a spontaneous seizure and they end up being diagnosed with nocardiosis. But it can also present indolently, or it can be confused with a CNS neoplasm. So someone, you know, we read about, I was reading about the former presidential candidate Eleanor Mondale, who presented with a CNS glioma with a seizure on a camping trip. Well, she did not have nocardiosis as far as I know, but just as an example, someone may present with a spontaneous seizure, have a CNS lesion, and then the question is, does she have a CNS neoplasm or does she have an infection? Well, Nocardia can be in that differential. And occasionally you can present with Nocardia meningitis, and that's mostly more of a subacute or chronic syndrome, but occasionally you can have CSF morphology that can mimic an acute bacterial meningitis. How about skin disease? Well, skin disease can present in one of 4 different syndromes. Primary cutaneous nocardiosis usually results from direct inoculation. Someone who's a gardener, for example, who's a farmer, who achieves skin trauma from, let's say, a thorn or even an arthropod bite or a bite from an animal, and develops a chronic dermatitis like what you see here. And you can also have occasion acute cellulitis where it's very hot and warm and suppurative, but that's less common. And usually a culture of the lesion can distinguish it from a typical pathogen such as staph or strep versus Nocardia. So generally in these lesions, a culture is advised because you can pick up a staph or strep infection versus a nocardiosis. Some patients have a lymphocutaneous syndrome. That's when you get more of a cold type of cellulitis with lymphatic spread, where you get a cold nodular lymphangitis, and this is called the sporotrichoid form. So you have the differential diagnosis of a sporotrichoid type of nodular lymphangitis, including Nocardia, but also sporotrichosis and non-tuberculous mycobacteria like Mycobacterium marinum, all being in the differential. Occasionally you have a disseminated Nocardia infection that presents with cutaneous features. So someone with let's say a widely disseminated Nocardia where the dissemination goes to the skin, you have skin lesions, but it's not a primary cutaneous Nocardia syndrome, it's a manifestation of disseminated disease. And then lastly, you can have Nocardia involvement of a mycetoma. So you may have somebody presenting with a Madura foot where the cultures grow Nocardia. And that can be very similar to actinomyces, and like other maduromycoses or madural type skin lesions, it can be refractory to treatment. So here's an example of some different cutaneous nocardia syndromes. Here's a primary cutaneous nocardia that may have been, I'm talking about the picture on the upper right, where the patient may have had a surgical infection or surgical instrumentation and then developed a nocardiosis. This is a patient on the bottom right who has a primary nocardiosis of the upper portion of the nose that may have been associated with local inoculation. I don't know this case exactly, but it may have presented as a result of a surgical dressing or a surgical procedure, or maybe traumatic inoculation, either outside of the hospital or nosocomially. The patient on the bottom left has a sort of more of a granulomatous type of nocardiosis. There's a little bit of surrounding erythema where you could sort of think this was a cellulitis, but it has more of a chronic appearance. And then on the upper left, this is a patient with a Madura foot where the cultures grew Nocardia. So these are all manifestations. Occasionally you may have a chronic dermatitis syndrome like this. This is chronic nocardiosis of the skin, and you can see there's just multiple of these very chronic appearing lesions, some with more acute features, where this patient, again, these chronic cases tend to be more refractory to treatment. So this is a patient who'd probably be on very prolonged therapy more aggressively to try to remit this syndrome. These are all miscellaneous clinical syndromes that can result from nocardia. Bacteremia can occur rarely, and when it does, it's typically associated with a foreign body. Occasionally you can even have nocardia osteomyelitis, although it's less common, I should say. Prosthetic valves can sometimes become infected with nocardia, and that can be a very problematic syndrome. You may get nocardia involvement of joints, nocardia infection of kidney tissue, and these are some other rare syndromes. I'll just mention pancreas involvement of the testes or prostate, ICD infections relating to nocardia, post-surgical mediastinitis involving, requiring surgical involvement, retroperitoneal abscesses, and endophthalmitis. So what are the differential diagnoses of nocardia based upon organ of involvement? Well, when you see nocardia of the lung presenting as a parenchymal lung lesion, you want to think about mold infections, of course, like Aspergillus or the zygomycoses. Of course, we want to think about non-tuberculous mycobacteria or TB. Either of them can be in the differential. And occasionally you see some bacterial infections like gram-negative rod type infections, or rhodococcus pneumonia presenting in a similar fashion. How about CNS disease? Well, you always want to think about brain abscesses, especially suppurative ones when there's multiple lesions involved, and we can see Staph aureus, bacterial brain abscesses, or others presenting with compatible CNS lesions. Think also about CNS mold infections, specifically Aspergillus, cryptococcosis, cocci or zygomyces. Toxoplasma can present with similar lesions, so can cysticercosis, and remember CNS lymphoma often being in the differential when you have nocardia brain lesions. How about cutaneous syndromes? We've already talked about the non-tuberculous mycobacteria, the sporothrix or sporotrichosis, cutaneous aspergillosis. Sometimes we see that in patients who are immunocompromised. And among the bacterial pathogens, think about erysipelathrix or francisella. Now, the one hallmark of the diagnosis of nocardia is isolation of the organism, right? in order to diagnose nocardia in a patient, you often you have to obtain the organism on isolation. Now that can be culture, of course, but you also think about if you see modified acid-fast positive organisms in a clinical specimen, then that's often pathognomonic of nocardiosis. Unfortunately, nocardia tends to grow very sluggishly in culture, and because it can present with such diverse manifestations, from CNS disease to pulmonary lesions to multi-organ involvement, that diagnosis can be challenging. Now, most routine media can support nocardia, so it's not one of those syndromes that you have to grow in very special media. But if you have a positive culture, it helps to have selective media like BCYE or modified Thayer-Martin to aid in organism isolation. And nocardia has extended growth requirements. It's not something that's likely to grow up in just a couple days. So if you suspect nocardia in a clinical specimen, it's important to call the lab and tell them, I think there could be nocardia in this specimen, because they have to incubate it for a lot longer period of time, and that can be up to 3 weeks. So think about the need for prolonged growth requirements in these specimens. And if you get nocardia in an isolation, it's imperative to get a species, and it's also imperative to get susceptibility testing. The reason for that is that nocardia isolates respond differently to different antibiotics. Not all of them are universally susceptible to Septra, for example, or carbapenems, or the aminoglycosides. So knowing what species you have and knowing specific information about susceptibility testing is very vital in treatment. So these are slant cultures looking for nocardia, and I'll just throw it out to the audience. Which one is nocardia? Is it the white one, is it the red one, or is it the yellow one? Which one is nocardia? No. But I like your thought process there, because you thought it was a trick question. That's good too. It's actually the one in the middle. So the yellow colonies are nocardia in this slant culture. So a question that always comes up in managing a patient, let's say with a nocardia pulmonary infection, is should I get a CT or MRI? Well, here's some general guidelines. Anyone who has CNS-related symptoms, who has extracranial disease, of course you would get an MRI or CT, right? That's only natural. If you have an immunocompromised patient with cutaneous or pulmonary nocardiosis, you generally always want to screen them for CNS disease, because an immunocompromised patient is always at risk for CNS disease if they have pulmonary or cutaneous nocardia. Somebody with pulmonary disease who's immunocompetent, so any non-immunocompromised patient with pulmonary disease, you always want to screen them for CNS disease. Now, if they have skin involvement, sometimes it's a judgment call. Generally, skin disease is less likely to disseminate in an immunocompetent patient. Did you have a question?
That was a question.
Yeah, so keep in mind that think about the possibility, and really in every patient, of CNS disease when they have extracranial involvement with nocardia. So you never want to miss a CNS process. Okay, so we're moving on here to treatment, and I think we're near the conclusion of the talk. But this is an important feature of the management of nocardia, so it's very important to keep in mind. So remember what I said, that not all species of nocardia are susceptible to the same drugs. So knowing the species and knowing susceptibility is very important. So here's some general principles about the treatment of nocardiosis. Number one, Septra is a mainstay of treatment, but resistance is variable and it may be increasing. So you can't always rely on Septra for every isolate of nocardia. Among the aminoglycosides, the drug with the greatest efficacy is amikacin, and other aminoglycosides may also have activity, like tobramycin, for example, but they're less reliable. Susceptibility also varies among the carbapenems. Can you treat someone with meropenem, for example? Well, as it turns out, it's actually imipenem which has the greatest sensitivity against nocardia. Third generation cephalosporins in general are much less reliable, so here's where you want to have your susceptibility testing. And other antibiotics to consider, think about minocycline, fluoroquinolones, maybe tigacycline, and in some cases dapsone. But remember, it's impossible to get dapsone nowadays because of its importance in the treatment of what am I thinking of here? No, Mycobacterium leprae in leprosy. It's also important to remember that there's never been a prospective randomized trial for the treatment of Nocardia. And it's very likely there never will be, right? Because this is such a severe infection that subjecting patients to a clinical trial for standard agents is very unlikely to ever occur. So all the treatment recommendations are based on accumulated clinical experience and really hypothesis. But it's generally accepted that if you have somebody with severe infection, you need to give them combination therapy. And that usually involves 2 or 3 agents typically. If you have somebody who's immunocompetent with skin disease, as little as 1 agent is acceptable. But immunocompromised patients, all bets are off and you want to treat them with multiple agents. And one of those agents, whenever possible, should be Septra, unless there's an allergy or susceptibility concern. So remember, Septra is always considered first-line therapy when you can give it. So let's say you have somebody with severe disease. Let's say they have a severe pulmonary nocardiosis. They're a stem cell transplant patient or a solid organ transplant patient. You want to treat them with aggressive therapy. It's usually accepted that primary therapy for non-CNS disease is typically trimethoprim sulfa plus amikacin. If they have a sulfa allergy, then you want to give them imipenem typically plus amikacin. If you have CNS disease, because of the CNS penetration, of the improved CNS penetration of carbapenems, you typically want to give them Septra plus imipenem. And if you have multi-organ involvement and they can tolerate aminoglycosides, you usually want to add amikacin. Here's some other treatment principles. Remember, susceptibilities are imperative, and unfortunately most labs do not do susceptibilities, so for the most case, a Nocardia speciation and susceptibilities require a send-out to a specialized lab. So this is not information you'll have very quickly. You need to send it out to a lab, and it may take a week or more to get this information back. And you want to think about the treatment of Nocardia in terms of induction and maintenance, right? So induction therapy is usually given for 3 to 6 weeks and or until clinical improvement occurs. And that's where you want to give them the very aggressive 2 or 3 drug, usually parenteral treatment. And you can wean your coverage thereafter based upon susceptibility testing and clinical response. So if you get someone with severe disease and they respond and they're treated for 6 weeks, this is a disease where you can change someone to maintenance treatment with an oral agent and then treat them for a prolonged period of time usually until their treatment is done. And then you decide whether or not they need chronic suppression. And as I say here, oral therapy may be considered after induction treatment, and you can use either Septra, minicin, in some cases even amoxicillin clavulanate for the treatment of Nocardia. What's the minimum treatment duration in a patient with cutaneous disease, maybe somebody who's immunocompetent? In those cases, maybe as little as 12 weeks of therapy is all that you need to do. Now, if you have somebody with who's immunocompromised, who has severe disease, the other end of the spectrum is even up to a year. So 6 to 12 months is usually accepted in an immunocompromised patient. But if they have CNS disease, that's usually treated for up to 12 months. And somebody who's immunocompromised who has CNS disease typically will put them on chronic immunosuppression, usually with Septra, minicin, or augmentin, so that their disease doesn't relapse. Typically you want to give them follow-up imaging studies to make sure their disease is resolving. And another question that's often asked is, when is surgical involvement important? Typically anyone with chest complications, someone with a soft tissue lesion that isn't getting better, sometimes surgical resection may be necessary. And in someone with pericarditis, that's usually a surgical emergency and needs intervention promptly. Here's some other management principles. If you have somebody who's on the calcineurin inhibitors, for example, and you can get by with decreasing doses to an absolute minimum, that's preferred. And somebody who's going to continue to be immunocompromised, let's say an HIV patient, someone who's had a stem cell transplant, or someone with solid organ disease, you want to consider maintenance suppressive therapy. And Septra or Doxy are usually preferred. So, so what are our summary principles in the treatment of nocardia? Remember, you can take this with you to Moffitt or any other place. Remember, nocardia is an uncommon environmental opportunistic pathogen, but one with the potential to cause significant disease in both immunocompromised, 2/3 of cases, occasionally immunocompetent, 1/3 of cases, individuals. Remember that Farcinica nova most commonly cause human disease, and that asteroides have been reclassified. Remember that pulmonary disease is most prevalent and can often disseminate to the brain. That's why you want to do CNS screening and imaging when possible. But non-CNS multi-organ disease also frequently occurs. Remember that in order to diagnose nocardia, you need to either culture it out or you need to see it as a modified acid stain in clinical specimens. And you want to treat severe disease with combination therapy for 3 to 6 weeks in induction, usually always including Septra unless they're allergic, followed by oral maintenance therapy for up to 12 months. And consider titrating immunosuppressant therapy, and consider chronic suppressive therapy in patients who are most severely immunocompromised.